Kia ora e te uri o tō rangatira, kia ora tō. Ki ngā kaimahi Māori, kairanga Hauora Māori ki Wanganui Atara, kia ora, te whanau o te Ripuranga Hauora Māori o Ero Pomari, kia ora koutou. Ka nunui ngā mihi ki o koutou, e tēnei wā, ko Andrew Sporle taku ingo no Ngāti Apa Rangatane me te Rarawa hau. Excuse me, I am extremely jet-lagged. For my sins of having an extra 3 days in France, have ended up with a rather hideous head cold. So, but I'm here supposedly to talk about NCDs, but what I want to talk to you about a different way of looking about NCDs. But in order to understand that, we need to know a little bit about the history of Maori health research and its impact on Maori health, and we are in the perfect place to do that. I am I'm not a full-time health researcher. I do a lot of health research development, and I do some governance issues on various health services in Auckland. I spend part of my time as a sociologist pretending to be an epidemiologist hiding out in the stats department at Auckland University. But one of the big things that we're doing now is working on Māori statistics, and that has a little bit of bearing about where we're going to go with this talk. So a Māori perspective on NCDs. In order to actually understand a little bit about the role of Māori health research, we need to actually go back to the beginning, and the beginning of that is very much associated with this place in terms of an Otago trained doctor who was from Taranaki Whānui, and Te Atiawa denoted the land on which we stand to build the hospital and the medical school. And Te Rangihiroa, or Sir Peter Buck, was from Ngāti Mutunga. He was the first Māori doctor to graduate in New Zealand. You probably know about that. But he was also a major political activist in bringing a group of reasonably disparate people, including a couple of his cousins, together to form the Young Māori Party and effect some political change early in the 20th century. But what you may not know is he actually published the first epidemiological paper in New Zealand, right? And it was a piece of community activism. It wasn't related to NCDs, it was related to infectious disease, but he did it as a piece of action research, and he was looking at housing conditions and their impact on Māori health during an epidemic. In fact, he gave up his job to go and work in the field for 6 months. Moving on some 60 or 70 years, and you end up with Ero Pomari, who I had the joy and blessings of working with for too short a time. Now, Eru was known to be the first dean of the medical school, being this medical school. He was also from Taranaki Whānui, being Ngāti Mutunga, Te Atiawa and Ngāti Toa, but also had whakapapa up the east coast as well. There is a short list of some of the things that Eru achieved. Brian Easton described him as a quiet revolutionary. He was able to effect structural change in ways that most of us could only ever dream of. He could do more in a meeting for Maori health than most of us could put together standing outside throwing rocks at the roof. Right? He was a true activist, but in his own quiet way. Now, one of the things that he did was to implement the Māori Standards of Health, or the Hauora series that carried on after his name, and to embed that in the structural reporting of Māori health, picking up from the occasional series reports of Rose et al. But he also founded the Māori Asthma Review. He was a chair and leader of the Māori Health, the first Māori Health Committee, inappropriately named because they were all sick, of the Health Research Council. He initiated the Māori Responsiveness for Research criteria for research funding. He founded the first dedicated Māori research, or one of the two first dedicated Māori research centres here in Wellington, Te Pūmanawa Hauora, which now carries his name. And he initiated the Wairarapa Asthma Project, and on his instructions, I broke a lot of rules to help Parry and the whānau start the Māori Gastric Research Project, and that's all you're going to hear about that today. But, so we've actually had about 100 years of Maori health research happening in New Zealand. So are we there yet? Are we there? Yes, there have been lots of improvements, but we have a long, long way to go. Equity in some of the basic metrics still remains elusive, despite the tens or hundreds of millions of dollars we've spent on research. And that is just the basic metrics, let alone including Māori Health definitions of Māori definitions of health and well-being. There have been huge improvements of data led by Paparangi and Bridget here at this university and the Ero Māori Research Centre, and there have been some improvements in terms of absolute rates with various health outcomes. Where there have been really big improvements is where there's been big policy focus, and what that has shown that change can be possible. We can affect breast cancer outcomes and screening rates if we actually try hard enough. But in relative terms, things aren't so flash. Now here's some work building on Eru's work. This is the results of coming out of a data visualiser or an equity visualiser that we're creating that will work with pretty much any health or social outcome data in New Zealand. But if you look at, carry on Eru's work on mortality and look at all causes of mortality, basically things are going in the right direction. Māori mortality rates are going down compared with non-Māori mortality rates, but it's pretty slow and things are still pretty bad. So let's have a look at something, setting the scene for a later talk. Let's have a look at stomach cancer. Now here's a time series going back all the way to 1963. For stomach cancer incidence, actually it's getting worse. The relative risk for stomach cancer for Māori has been increasing since 2001. We are not quite sure why yet, but hopefully HRC funding willing, we'll find out in the next few years. But it's currently Māori have an incident rate of 3.2 times higher than that of non-Māori, and it seems to be getting worse. In terms of stomach cancer death, then the pattern is less sure, and here we have that big data quality issue that the Ero Māori Research Centre were instrumental in getting resolved. You can see the break in the timeline. So, but what we can see from here, from 1996 onwards, is that there is an uncertain trend. It looks like it might actually be going down, but the variance is such that we don't really know. But still, the death Māori, we still die of stomach cancer 3.7 times more frequently than non-Māori. So we've got persistent differences in mortality and cancer. And are these due to some health systems effect? And again, this is some research that emanates from this university and this medical school. This is Di and Tony's work and their teams. And basically what it shows is that the inequalities in this case, colon cancer, is actually the cumulative effect of a series of small incremental differences at each stage of the clinical care pathway. So the outcome, it isn't one big, easy to focus on thing. It's a whole series in the clinical pathway. But surely these health effects are decreasing. I mean, we're supposed to be focusing on this. DHBs have it in their reporting guidelines, and we now actually, again, the Ero Māori Research Centre produce DHB-specific Māori health reports. So surely things are getting better. Now, carrying on some of Eru's and Neil Pearce's work, this is the time trend for amenable mortality from 1996. Again, this data has not been published. This is hot off the press. And what we can see is for amenable mortality, which is 14 really specific conditions that you just should not die of if you've got access to routine medical care, we might have a very slow decrease. I mean, this is fundamental basic stuff. This isn't bells and whistles medicine, okay? This is fundamental stuff. And all we're getting, even in the last 20 years, is a very slow decrease. And so we're still dying twice as often than non-Māori of something really, really fundamental, well, fundamentally preventable. So people often talk about Maori health and building resiliency in Maori health communities, but one of the most resilient things I've ever seen is actually the resilience of the healthcare system to change. And one of the things, what this shows to me is that if we're actually going to wait for the healthcare system to address this, we're going to be waiting for a long time. But if we have a look at Martin Tobias's more broader definition of amenable mortality, we see a slightly rosier picture, but still the decrease over time in the relative risk between Māori and non-Māori is actually very slow, despite the efforts. And if you actually look at ambulatory sensitive hospitalisation rates, our ambulatory sensitive hospitalisation rate is over 1.5 times that of non-Māori. So there is something fundamentally wrong with how we deliver healthcare services. However, it's not all bad news. There's been some good news, and some of that good news is old, and some of that good news has actually been research-driven. Again, another project that's come from this university, led by Eru and Neil and the Wairarapa asthma project, was Te Reo Ora, which was a very short, very small funded community-based intervention to address very, very high rates of emergency hospitalisation for asthma. What that project found was it was a community intervention. That designed a response that was related to how they worked. It was very brief. It was only several months long. It developed a whole new approach for doing things, but it ended up with a long-term reduction in admissions, even 6 years later, from a total investment of less than $50,000. So if you do things differently, right, you can actually make a change. A more recent intervention, and one that has actually made the news, is the Hauora, or the woven flax bassinet intervention for reducing Māori SIDS rates. It has been shown to be just as effective and safe as keeping your baby in a bassinet. But again, it's a community initiative. So what we've found so far is making changes to Maori health at a national level has only worked where there's been a really focused policy effort. And on a more local level, it's the research partnerships that are actually producing new solutions. And one of those is actually Parry Guilford and the McLeod whānau working with stomach cancer. Here we had some hard-end cancer geneticists working with a Māori community to address a need identified by that Māori community. And what they were able to do is produce, by combining their two realms of knowledge, they produced some fantastic science that, although it was funded for 6 months, they found the results funded for 3 years. The whakapapa information provided by the whānau was such that they found the results in 6 months, and as a result have changed the face of stomach cancer research worldwide. So, should we be optimistic? Well, actually, yes, right? We should be optimistic because there's some big things happening. And one of them's got nothing to do with us. One is just the demographic momentum in the Māori population. Secondly, is we're seeing big changes in the way that services are delivered to Māori, mainly outside the healthcare sector. And part of that relates to new ways of Māori-driven community development and community change. And a final thing is the way that this particular science challenge has been funded in order to be translational and transformative, rather than deliberately moving away from yet more descriptive research. So we're beginning to see Māori values-driven interventions happening at a local level and happening nationally, and those are begun to be informed by data, big data. The iwi Chairs Forum have appointed not only a Whanau Ora working group, but they have also appointed a data working group, right, that will be meeting specifically with ministers to make sure that the health data and the integrated data infrastructure, as it emerges, will work for Māori, right? They won't be negotiating with us, they're negotiating directly with the Crown. People like me will be at the coalface operating under their instructions. But this has been picked up by the iwi Chairs Forum. It is going to happen. So, what is the potential demographic dividend? those of you who haven't done demography, a triangular population pyramid like that means that the Māori population is rapidly growing. We've got a median age of just under 24 years. And what that means is, unlike the mainstream population, where at a not too distant future there's going to be more old people than there are kids, we've got this going on. Okay, we're going to have both populations increasing. We will, in 10 years, have more people over the age of 65 than we had people 140 years ago. So what that means for health care and research is, and improving Māori health, is that prevention is going to be the name of the game, right? Because we're going to be able to work with a large population of rangatahi and tamariki as they grow up. We've got opportunity for prevention on a large scale. But also, at the other end of the life course, we've got a rapidly increasing number of elderly Māori who are carrying with them into their old age a lot of comorbidity, right, and high social needs as well, quite often urbanised. The next big thing that's happening is Whanau Ora. Now, hopefully you've all heard of Whanau Ora, but basically how this differs is it embeds Māori values, including a Māori understanding of well-being, into social and healthcare service delivery. It wraps services around a whānau, so it's looking at improving both individual well-being with all these components that you see there, but in a whānau context. So the health element that we see is very much individual and whānau level driven. So we're not talking about, in here, we'll no longer be talking about NCDs affecting individuals, it's how they impact whānau. And the interventions will be at the whānau level. The measurements of outcomes will be at the whānau level, right? Not just at the individual level. Those metrics are currently under development in a program led by Mason Jury. So yes, it is going to be about improving healthcare access, but in the context of a Māori definition of both individual and whānau wellbeing. So our role as researchers is actually going to change. Our focus is going to change, and what we measure is going to change. The other thing that is happening is we're beginning to see Māori-driven community development. Now, this isn't just community development for Māori communities. This is Māori-driven community development for everybody in their area. This is the Ruapehu Whānau Transformation Plan that has been recently published with the Makaurau sisters working on the data side. And basically, here we have Kōrero Ruapehu, who is looking after everybody in his shadow. And what is happening is all the iwi and hapu in the area have combined, and they've worked out a development plan that includes health, that includes addressing NCDs, but isn't specifically focused on it, with the understanding that it's very difficult to address somebody's asthma if they've got housing issues, right? It's very difficult to address somebody's asthma if they're constantly mobile, if they're not engaged with a carer, right? If they don't know how to monitor their own or their children's health. So it's a new way of looking at social service development, community development at a community level, at an area level. And this is not just for Māori communities. It is actually intended for everybody that works in that area. It's not exclusive, it's inclusive. But again, the intentions, the interventions, and the metrics by which it will be assessed are all going to be different. So what does this mean for us as NCD researchers? And the first thing is we actually need to stop and think. We need to think different. 100 years of research and we're still getting really, really, really slow change, right? More of the same is not going to work. And don't expect Māori to support it. Secondly, we need to focus on disparities. Even the NIH recognises this, that if you're working in an area that affects a minority group or women to a greater extent than the rest of the population, then any research that doesn't specifically address those disparities will actually make those disparities worse. So if you have a mainstream project that is not addressing the impact of that particular issue on Māori, you're actually not part of the solution for us. You're actually in our way. One of the hard things for researchers, especially researchers like me who have to apply for funding every few years, is we actually have to get stroppy. Right? We actually have to be those change agents. Not everybody can be an eru and work behind the scenes. Right? We actually have to start to affect change. This is about being transformative, so we need to start partnering up with change agents and disruptors. Right? This means that we may be the information providers, right, who are actually loading the gun for the people to make the difference. This is the role Te Mana Oranga has with the iwi Chairs Forum, is we're providing the iwi chairs with the information to go and negotiate with ministers. It is not our role to try to affect that transformation. It is not what we're good at. But it also is a difficult position for people in a contestable funding environment, and it's one that we really have to consider with the future of the science challenges. But achieving if you look at the mission for this Healthy Lives Science Challenge, we're actually going to face some challenges as researchers. First of all is Māori are going to present you with different definitions of outcomes, different definitions of determinants, and different ways of measuring or assessing those particular variables. We're going to ask for different governance structures. This is not about being consulted anymore. This is actually making a difference. And in all the other areas where Māori, especially in the economic domain, where things are happening and they're happening rapidly, we're ending up with co-governance models. We keep going back to the treaty framework and we're ending up with models of economic development and innovation that are based on co-governance. I see a very strong role for that here. But a big issue is timeframes. If we're really going to start to think about addressing Māori health and well-being in Māori terms, we're talking generations. Now that is very hard to do in a 5-year project. It's virtually impossible to do in a 3-year project. So that maybe it means that we actually have to start looking at and cooperating and coming up with different metrics and different intermediary variables or milestones to assess. But say, for example, in Taranaki, right, you can't really assess Māori well-being in Taranaki unless you understand the history of Taranaki. And recognising that and doing something about it means that us as researchers are going to have to broaden our horizons and consider different ways of doing things. Thanks very much.